So moving on to the next session, which is a plenary on update on lipid lowering therapy. May I now invite Professor Priyamali Jayasekara and Dr. Dilshan Pereira on stage.
Good morning, everyone. So we are starting the first plenary lecture of the day. It's on update on lipid lowering therapy. May I introduce our speaker? Is Dr. Vinaya Simha, MBBS MD, is a consultant in the Division of Endocrinology and Associate Professor, Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota. Over to you.
Very much. Once again, thank you. Thank you for the organizers for this very kind invitation and for the opportunity to share some thoughts about an update on lipid lowering therapy. So before we actually start on how, I think we should ask the question why. Why is lipid lowering therapy relevant? The point I want to make is this. Lipid lowering therapy is not about lowering lipids. It's not about moving your cholesterol from point A to point B. Now, if there are any interventional cardiologists in this group, so you know what keeps you up at night is people having the so-called sudden heart attacks and so on. But for all of us, for you and me who are not interventional cardiologists, what should keep us up at night is this question, is that there is really no such thing as a sudden heart attack. What is happening right under our nose and under the patient's nose, as you can see as well. And so this is a process that's going on for a long time. And since it goes on for a long time, it also affords us a lot of opportunity for prevention. And that's what lipid lowering therapy is all about. It's about lowering the risk for cardiovascular disease. And it's not that we are not doing this. We have done quite well, reasonably well, I would say. And the workhorse has been statin therapy. So we've been using statin therapy not for lowering cholesterol, but for reducing mainly ASCVD through lowering LDL cholesterol. And we are doing it so much that the lay press actually ridicules us that we are overusing statin. So this was a cartoon in the New York Times which said the new indications for statin therapy. Step 1, check your pulse. And step 2, if you have one, you should be on a statin drug. So we've been using quite a bit of it, but we have been doing this for a reason. And the reason is we have umpteen studies. These are all the landmark statin trials which have uniformly shown improvement in ASCVD outcomes, overall mortality, and this is with both the primary prevention and also secondary prevention. So using statins, there is almost a linear relationship between LDL cholesterol lowering and event lowering. So it's a good thing that we are using statins. In fact, as recently as just 2 years ago, the USPSTF had commissioned a task force to look at all the data we have on statins. So they looked at quite literally every single study that has been done on statins. And again, this meta-analysis showed that there was a reduction in all-cause mortality, there was a reduction in cardiovascular mortality. And they also looked at one of the concerns these days has been in terms of the new onset diabetes in people who are on high intensity statin therapy. This started with the Jupiter study where people on high intensity rosuvastatin had a higher risk for new onset diabetes. The meta-analysis itself did not suggest any increased risk. So overall, to summarize, this is what we know about statin therapy over the last 30 years. So clearly, there is a reduction in all-cause mortality, there's a reduction in cardiovascular mortality, and these other endpoints, it's not just the composite endpoints, but also the individual endpoints of non-fatal MI, revascularization, stroke. So all of these are favorably influenced by statin therapy, and there is really no increased risk of any appreciable adverse effects. So whether it be the cancer, diabetes, myalgia, rhabdomyolysis, so at least in the large trials, we don't see a clear signal. So statins are safe and they are effective. But can we stop here? And so therefore we have all these guidelines which clearly say that almost everybody should be on a statin, especially those who are 40 to 75 years of age and are at high risk. But then, can we actually stop here? I showed you that almost every single study on statin has been beneficial. But you can also flip this graph around and then you will see, so this is the burden of the residual risk. So when you actually flip this slide over, then it is not about the glass being half empty, it is way more than half empty. So there is so much of residual disease that we are not preventing with just statin therapy. So how do we address this enormous burden of residual risk? Now, first of all, most patients are not even on statin therapy. But even if you have everybody, if your wish is to get everybody on appropriate doses of statin therapy, even after that, there'll be so many people who are still experiencing cardiovascular disease. So how do we manage that? To my mind, we can do it in one of the three ways. One, we can be more aggressive with LDL cholesterol reduction. Two, we can target triglyceride-rich lipoproteins. So basically try to use these triglyceride-lowering therapies. Or number three is to use HDL-targeted therapies. So let's look at the data for each one of this. So let's start with more aggressive LDL cholesterol reduction. So we can do this by using one of the older drugs like say ezetimibe. So this was the IMPROVE-IT study. You're probably familiar with it. So it's now over almost 15 years since the study came out. And the long and short is that when ezetimibe was added to simvastatin, there was about, so as you can see here, there was just about, you can see this is a very powerful study. So there was just about a 7% relative risk reduction, though in people with diabetes, it's about 15%. But then the fact that they had to do this study in 7,000 people who are at high risk shows you that the effect is probably not too great. So it was enough to actually get a regulatory approval. So, but nonetheless, adding ezetimibe, which is inexpensive, which is safe and well tolerated, would be probably our first step in terms of more aggressive LDL cholesterol reduction. What is even more aggressive is the use of PCSK9 inhibitors. Again, these have been around for quite some time, so I assume that most of you are familiar with how they work. So, but then just for those of you who don't really follow this field much, so you know that it is the LDL receptor on the hepatocyte membrane, which is primarily responsible for clearing the LDL particles. So, you know, this is the LDL receptor which takes up the LDL particle, and then after having released it into the cytosol, it goes back to the surface. So it keeps doing this all the time, unless it is associated with this other protein called PCSK9. So if the LDL receptor is associated with PCSK9, then unfortunately it cannot escape the lysosome, and so you will get basically it chews up the LDL receptor. So you get decreased recycling of the LDL receptor and less efficient clearing of the LDL particles. So this is what we found out in people with very high cholesterol, some people with very high cholesterol levels who had an activating mutation in the PCSK9. But that also led us to this pharmacological approach of down-regulating PCSK9. And so we have ended up with these two new monoclonal antibodies, alirocumab and evolocumab, which down-regulate PCSK9 and in turn will upregulate the LDL receptor, more effectively lowering LDL cholesterol. And it's very effective. So you can see here. So there's almost, when added on to statin therapy, there's anywhere from 50 to 60% LDL cholesterol lowering, which is durable, sustained. So you can see this is over a 4-year period. And it's not just about LDL cholesterol lowering. There is very good data showing this is plaque volume reduction. So this is data where in the GLEGOB trial, so they did intravascular ultrasound, and then you can see that as the LDL cholesterol keeps going down with the combination of evolocumab and statin, the volume of the atheroma on this intravascular ultrasound goes down. So we have data about that, but then what we really want is clinical outcomes data. And yes, we have that too. So this was the Fourier trial, so where evolocumab was shown to reduce the risk of ASCVD endpoints. Of course, there's a lot of controversy about it. They stopped the trial a little early, and that's why we think that it was in some ways underwhelming. The absolute risk reduction was only 1.5%. But nonetheless, we clearly know that adding a PCSK9 inhibitor monoclonal antibody will lower LDL cholesterol and will lower ASCVD events. What by way of an update? So all this was what we have known for the last 10 years. What is it that is new for 2023, 2024? The main thing which has been extremely interesting has been the development of these small interfering RNA. So we have these silencing RNAs which has been developed. So one of them is this inclisiran. So basically these are double-stranded RNAs. So one of these strands will go and activate this RISC complex, and the other strand will recognize PCSK9. And what the RISC complex does is it will chew up all the PCSK9 messenger RNA. So, you know, Dr. Ramasubramanian was telling about how in US everybody gets, every 6 months they go and get a COVID shot. Now, all you need to do is to at the same time also get this one shot of inclisiran, and your cholesterol will be low by 50-60% for the next 6 months. So that's what this new technology has enabled us to do. So this is data on this highly durable RNAi. So they got this injection one, and you can see up to 180 days, there is about a 40% reduction in LDL cholesterol. So we have this very minimally disruptive medicine to my mind. And then is it effective in terms of lowering event rates? We don't know that. But then we do know that it's quite effective for cholesterol lowering. So this is the Orion trials, so where they have looked at the effect of inclisiran in patients with heterozygous familial hypercholesterolemia. So these are people with genetic hypercholesterolemias, extremely high cholesterol levels. So you can see, so these were people who were already on statins, on ezetimibe, and still have an LDL cholesterol over 150. And when they were treated with inclisiran, so you will see this again. So there is about a 40 to 50% lowering of LDL cholesterol. So we have this very good drug. And but yet, unfortunately, we still don't have outcomes data. So as of now, it is mainly approved as treatment for patients with heterozygous FH or in patients with established ASCVD who have not achieved adequate cholesterol reduction with statin therapy. So it's provided as a sub-Q injection. So at least I don't know whether it's available here. So I don't think so. We'll actually skip this, how to use it clinical. So I hope that it will become available. The main concern is this. Look at the cost. I almost feel kind of apologetic and ashamed to put up this slide in the sense, just like 20 minutes ago. So we had such an elegant presentation on how you can just do a leg raising test and you can improve the care of patients with shock. And here I am touting a drug that is $3,475 a vial. Okay. So I know Sri Lanka is doing quite well now than it did a few times ago. But if you start using these drugs, I can assure you it will bankrupt most economies. So, and this is not just, but this is more in terms of academic discussions. Okay, so there's a lot of new things that is happening. So there are new and emerging therapies for severe hypercholesterolemia. One of them, of course, is inclisiran. But now we are having these, people think that we'll have other gene editing therapies. So we'll probably have CRISPR. So who knows? We won't even need every 6 months injection. So you'll probably have this CRISPR technology to simply chop out the PCSK9. And then we are also doing something on this ANGPTL3. I think that's again a very interesting player that's emerging. So what is ANGPTL3? So just to jog your memories on your biochemistries, lipid pathophysiology. So the way we actually deal with lipids, so whether it be the exogenous dietary lipids or the endogenous lipids make in the liver, is to make this VLDL and chylomicrons. And these are initially hydrolyzed by the lipoprotein lipase, and then you get these remnants and LDL and so on. But this lipoprotein lipase, basically, so it is inhibited by two other enzymes, or rather, two other proteins primarily. One is the ApoC3 and the other is this ANGPTL3 and 4. And so what people have been trying to do is, can we block the activity of this ApoC3 or ANGPTL3 to increase the activity of lipoprotein lipase? And the idea then is to improve the clearance of this triglyceride-rich lipoproteins. And so they did that. And then one of them is this anti-ANGPTL3. So this was primarily developed as a triglyceride-lowering therapy. And it indeed does that. So you can see that there's nearly a 70% reduction in triglycerides when you use this medication, evinacumab. But then somebody had this very bright idea of trying this even in patients for cholesterol lowering. And here they took the people with the most super high cholesterol levels, people with homozygous familial hypercholesterolemia. So where there's a biallelic mutation in LDL receptors. So these were people who had a mean LDL cholesterol of over 250 when they were already on a statin, PCSK9 inhibitors, ezetimibe, lomitapide, LDL, quite literally everything that we know of for lipid lowering. They're already on that and still their LDL cholesterol is 250. What happens when you give them this evinacumab? Lo and behold, again, there is nearly a 50% reduction. So we have all of these very novel, powerful therapies which are available, which can lower LDL cholesterol way more effectively. Again, do we know whether all of this will lower risk? We don't know. But then going off on the paradigm that there's a linear relationship between LDL lowering and event lowering, I think they will. So one of these days, probably they will become more affordable to everybody, and that might help us change the landscape of ASCVD risk reduction. So again, I don't think it's available. So let's not go into the how much to give and when to give and so on. Okay, it's administered as an IV infusion every 4 weeks. And if the other one was expensive, look at this. This is $450,000 a year. Okay, so these are, it's not really for prime time use just. There is one other drug which I think is very interesting, and this is bempedoic acid. So I always tell my students, okay, we have statins, and then we have PCSK9 inhibitors, which is like the elder brother of statins in the sense that this is the powerful big bully that lowers LDL cholesterol. And then we have bempedoic acid, which is like the gentle little sister of statin. And I say that because it works very similar to a statin. So as you know, statins will reduce the cholesterol synthesis in the liver, and therefore the liver will make more LDL receptors. In much the same way, bempedoic acid also does the same thing. It also interferes with the pathway of endogenous cholesterol synthesis. But then it's a little different from statin in that it's a pro-drug and it has to be activated. And the activating enzyme is present only in the liver and not in the muscle. So in that way, this is a liver-specific statin. So all the muscle adverse effects of statins that we see are not seen with bempedoic acid while getting all the benefits of a statin. So that's the advantage of bempedoic acid, so which is an oral medication. I assume that it should be available. I know it's available in India, so perhaps this is available here as well. So this is an oral medication. We have very good data now. So we have these so-called CLEAR trials which have looked at both cholesterol lowering and event lowering in people as an add-on to statin therapy and also as alternatives to statin therapy. And they have been quite good. So they lower LDL cholesterol modestly. That's why I said it's like a gentle little sister. So this is not like 50% reduction. So it's about 15-20% reduction. But the reason why all of us are very excited about this is this. It also lowers CRP, which, as you know, is a marker of vascular inflammation. So there's nearly a 25-30% reduction in CRP, way more than what we would have expected for the LDL cholesterol reduction. Like when compared to ezetimibe, you can see that, ezetimibe is more effective in lowering cholesterol. Bempedoic acid is more effective in lowering CRP. And why are we so excited about CRP? So again, this is a very provocative study. So where they looked at whether it was LDL cholesterol or CRP, which predicted risk in people who are already on statin therapy. And when they pooled the data from 3 large studies, so this is what they found. So it was the higher levels of CRP and not LDL cholesterol which predicted the risk. So we really need to target CRP as well. And this drug does that. So it lowers LDL cholesterol, it also lowers CRP. And we think that that's why we saw this very impressive outcome trial called the CLEAR outcome trial, so where they took patients with statin intolerance and then they were randomized to either get bempedoic acid or placebo. And you can see that the LDL cholesterol lowering is about 15-20%, but then the CRP goes down by 25-30% and all the outcomes. So whether it be the composite MACE or the 3-point MACE or the non-fatal myocardial infarction or coronary revascularization, all of these were favorably reduced by bempedoic acid. So this is something that you can consider in your patients either as an add-on to statin therapy or as an alternative to statin therapy in patients who cannot take statins. There's one concern about it also increases uric acid. So if you have a patient who has known gout, you should be cautious about monitoring their uric acid levels. So this is, as I told you, this is an oral medication, 180 milligrams administered once a day. I don't know what the cost is here, but it's considerably less expensive. In India, I know that it's reasonably priced. So that's one thing. So the next step that we can do is to look at triglyceride lowering therapies for cardiovascular risk reduction. So here we can either use a fibrate or omega-3 fatty acids. So which one can we use? So I'll start off with the role of fibrates. Okay? So the fibrate, so there was this, and by way of an update. So the most recent trial we had was called the Prominence study. So where they looked at triglyceride lowering with a fibrate called pimafibrate to reduce cardiovascular risk. As a backdrop, we always knew that fibrates are probably effective, at least in people with high triglycerides. So if you look at all the previous fibrate trials, some of them showed benefit and some of them did not show a benefit. But when you looked at the subgroup of patients with high triglycerides, there was uniform benefit. So all along we thought that if only we had a study where we enrolled the right patient group, then we can show that adding a fibrate will lower the risk of cardiovascular disease to a statin. And this was supposed to be that study. So they took patients with diabetes who had already had hypertriglyceridemia and low HDL cholesterol. And this was a very potent fibrate. And, these are all the baseline characteristics. And this was exactly what you wanted to do. So you took patients who were on statin, their triglycerides were 270, HDL was 33. And then we found that there was a 25% decrease in triglyceride levels, ApoC3, all of these things. So this was like, what happened recently in the India-New Zealand series. So they got a spinning track, they got the 2 world's best spinners, and they were expected to win, okay? But look at this, lo and behold, there was absolutely nothing that came out of it. Just like India lost 3-0. I hope Sri Lanka will do better. New Zealand, I believe, are touring here. So that's what happened. So despite actually getting the right study, we found that adding a fibrate to statin therapy did not reduce the risk of cardiovascular disease. Unlike, as I said, something else, like I hope Sri Lanka will do better, like how EPA has done. So there is a trial of icosapentaenoic acid. So that's one of the fish oil derivatives. So where adding that to ongoing statin therapy has been like, this is unbelievable. So this showed an relative risk reduction of 25% and absolute risk reduction of 5%. There's almost no drug which has an ARR of 5%, but the EPA was shown to do that. And sometimes when something is too good to be believed, you don't know whether to believe that. And there are people who actually think that, mainly because, here's the thing. So this is the event rate in the placebo group, and this is the event rate in the people who got EPA. And this is a superimposition of 2 curves. One is those whose triglycerides were lowered, and the other is people whose triglycerides were not lowered. So it's almost as if the event lowering had nothing to do with triglyceride lowering at all. So all along they're using this drug to lower triglycerides and thinking that, if you lower triglycerides, you will lower cardiovascular risk. No, that's not even true. So we don't completely understand, and but then we think that when we don't understand, we are never short of other hypotheses. So we think that maybe it has an antithrombotic effect, membrane stabilizing effect, but then there are also these conspiratory theorists, so to say. So somebody did this very provocative study where they kind of superimposed this data on a large population database, and then the point of this study was to say that maybe it was all because of the pro-inflammatory effects of the placebo that they used, so which was mineral oil. And so when you are comparing a very pro-inflammatory placebo with this probably ineffective drug EPA, because the combination of DHA and EPA has not been shown to be effective. So we don't know. So maybe it is that or maybe it is not. So we'll never know unless we do a study where both drugs are simultaneously used. But nonetheless, the available data supports that adding EPA to statin therapy may be beneficial, while adding a fibrate to statin therapy is not. So I have 1 more minute and I have a whole another third of the talk, okay? But no, it's not a third of the talk. I deliberately kept HDL therapies to the end because unfortunately we don't know whether there are any benefits. So we've been talking about these novel HDL-based therapies for so long. People have tried to look at these recombinant HDL, ApoA1 Milano, oral ApoA1 mimetics, and then there were all these CETP inhibitors. I've given talks, 45 minutes on just CETP inhibitors. There was a time when we were really excited about these things. They increase your HDL cholesterol by 100%, 150%. But yet, as you can see, almost all of them have not been shown to reduce cardiovascular risk. And more recently, there are these very, very provocative data. This is from the UK Biobank, so which has shown that there almost seems to be a J-shaped curve. It's not like everybody with high HDL cholesterol is benefited. It almost appears that compared to people with an HDL cholesterol of 40 to 60, men who have a HDL cholesterol over 80 are actually at increased risk. And 60 to 80 is not even protective. And that's the same thing with women as well. So we don't completely understand what is the role of HDL yet. So in conclusion, lipid-lowering therapy in association with healthy lifestyle practices, I assume that that's a given, okay? It has to be always on the backdrop of healthy lifestyle practices. It has the potential to reduce overall ASCVD risk. Statins are the primary workhorse for doing this, but there is still an enormous residual risk after statin therapy. And we can probably address some of this by using more aggressive LDL cholesterol reduction with ezetimibe, PCSK9 inhibitors, and bempedoic acid. We really are not yet sure about the role of triglyceride lowering therapies. Perhaps EPA has a role. Fibrates as of now they are still very useful. Don't throw away your fenofibrate and gemfibrozil. They are useful for triglyceride lowering and prevention of pancreatitis. But as an add-on therapy to statins for cardiovascular risk reduction, we don't have good data to benefit that. And HDL, unfortunately, I don't know much about it, and I don't think we'll ever really know everything about the HDL. Thank you very much.
Thank you, Dr. Simha, for that excellent update on lipid-lowering therapy. Ladies and gentlemen, this being a plenary, we don't have Q&A. Therefore, I would like to call upon my co-chair, Professor Priyamali Jayasekara, to hand over the certificate of appreciation to Dr. Simha.
Thank you, dear sir, for sharing those valuable updates about lipid lowering therapy. And thank you, dear chairpersons, for moderating the session.